and the rest 10 as gynecology. Before I start, I would just like to remind you that we are having various live sessions of all these subjects, OBS Gynae, as you can see. I will be having a session on 12th February as well. Anatomy Radiology will be there on 16th and 18th. So don't forget to miss this. So let's straight away start the questions without wasting any time. As I told you, first 15 will be obstetrics. So question 1. Which of the following is not in quadruple test for antenatal detection of Down syndrome? Now, there are a few points which you should keep in mind because it's AIMS. They are not going to give you very easy questions, okay? So, first of all, quadruple test, that is the thing for antenatal detection of Down syndrome. They are very clear that for Down syndrome, what is it? Actually, quadruple test is now indicated for all pregnant females, okay? But we know that the most common congenital anomaly or chromosomal anomaly is actually Down syndrome. So, quadruple test, what are the 4 quadruple tests which you should know? The options are alpha fetoprotein, beta HCG, estradiol and inhibin B. So I hope all of you will answer that. I would also like to confirm that my audio and video are clear. I can just get a message from anyone that my audio and video are clear. My audio and video are clear. Yeah, I guess I can continue. So remember that quadruple test is a second trimester screening test. First number thing. Now what quadruple means? 4. The 4 test will be alpha fetoprotein, unconjugated estriol. Please remember there have been MCQs for this also. It's unconjugated and it is estriol. Not estrone, not estradiol, HCG and inhibin A. So I know that answer is very clear now. It's not inhibin B, but it's inhibin A, which is actually a marker of quadruple test. Okay, and it's a second trimester screening test which is done between 15 to 20 weeks. For Down syndrome, there's a simple mnemonic I would like to share with you to remember easily. It's high. Okay, so this means what? HCG and inhibin. Okay, they will be high. These 2 values will be more than the normal in Down syndrome, and alpha fetoprotein and unconjugated estriol will be less. So, but remember this is only for Down syndrome. For other syndromes, it's actually all values are decreased. For Down syndrome, high means HCG and inhibin A will be increased. So remember there's also something called as triple test. Triple test means you have removed the inhibin test. Okay, so alpha fetoprotein, HCG and again unconjugated estriol. They form the triple test, but remember this is now an obsolete test. We don't use it usually because now quadruple test is available. And also know the double marker test. Now this is a double marker test is very important, advised in all pregnancies from the time of 11 to almost 13 plus 6 weeks. Okay, so it's a first trimester screening test again by keeping Down syndrome in mind, and beta HCG and PAP A. Okay, these 2 are the important marker tests in the double marker test. Moving on to the second question. Active management of 3rd stage of labor. Active management of 3rd stage of labor. Okay, that will include all except. So ergometrin after anterior shoulder delivery, uterine massage, cord traction and oxytocin infusion. It's again a question from AIMS. So remember ergometrin after anterior shoulder delivery. Always the uterotonics should be given after the delivery of the anterior shoulder. Okay, uterine massage, we'll see that. Cord traction, okay, it's a controlled cord traction. That means the umbilical cord has to be gently pulled out. Okay, at the same time you have to give support to the uterus with your other hand. That is why it's called as controlled cord traction and oxytocin infusion. So what will be the answer you're expecting? The answer is actually yes, uterine massage. Why? Because let me clarify that also. The 4 points of active management are immediate administration of prophylactic uterotonic. Okay, so don't think ergometrin is the wrong answer, because the guidelines say that uterotonic, anything which contracts the uterus, can be given after the delivery of the anterior shoulder. Controlled cord traction, delayed cord clamping. Please remember, delayed cord clamping is there, not early cord clamping. And intermittent uterine tone assessment. You just have to intermittently see whether the uterus is contracted properly or not. There is no role of uterine massage which is advised regularly for patients. So the answer for that will be uterine massage. Don't confuse that your oxytocin is the only uterotonic. I am repeating again, any uterotonic can be given. Of course, there are some contraindications for ergometrin and there are some contraindications for delayed cord clamping also. But the question is not asking that. The question is straightly asking what is not included in active management of third stage of labor. So for that, of course, massage will never a part of the uterine management, third stage of management. Coming to the third question. A 28 weeks pregnant female on examination, this is a scan. So it is of umbilical artery. As you can see, what will be the next aim of management? Again, this is AIMS question. So basically now they are expecting you to even read some basic at least ultrasound findings. Okay. So just have a look at this image properly. See what it is and then I will explain you in the next slide. So if you see this image, okay. So this is umbilical artery, okay. Now we all know that umbilical cord is having two umbilical arteries and one umbilical vein, okay. We read the Doppler. Doppler means simply the blood flow. In simple words, Doppler means blood flow, okay. We have to see the blood flow in the umbilical artery as well as uterine arteries. So coming to the umbilical artery, why? Because umbilical artery is actually telling you ki how is the baby doing, how is the baby well growth happening, okay. For that, umbilical artery will tell you. Now if you see, this is a systolic and this is a diastolic, okay, systolic and diastolic, systolic and diastolic. So if you see, this much is a diastolic, okay, this D which I have written, if you can make out, this is the diastolic part, okay. So remember, जैसे pregnancy बढ़ती जाती है, we want that the baby should get more and more of blood supply, isn't it? तो इसलिए जो diastolic का blood flow होएगा, वो time के साथ बढ़ना चाहिए. Why? Because the demands of the baby are increasing. इसीलिए डायस्टोलिक का ब्लड फ्लो शुड बी अप्रॉक्सीमेटली 1/3 ऑफ द सिस्टोलिक ब्लड फ्लो. इतना आपको समझना है दैट ये सिस्टोलिक वेव है तो उसका 1/3 तो एटलीस्ट डायस्टोलिक होना ही चाहिए. बट यू कैन सी वो भी कम है इसमें. द डायस्टोलिक इज नॉट इवन 1/3, ओके. सो कमिंग टू द बी ऑप्शन, इफ यू सी, सो ऑफकोर्स इन ए व्हाट यू विल सी इज द डिक्रीज्ड एंड डायस्टोलिक वेलोसिटी. व्हाट यू मीन बाय एंड डायस्टोलिक वेलोसिटी? सिंपली कि भाई डायस्टोल जब खत्म हो रहा है तो खत्म होते होते हाउ मच इज द वेलोसिटी, ओके. Some doubts I'm getting. Yeah, so a student has asked what is PAP A. Okay, so I'll just quickly go to that question. Yeah, so PAP A is pregnancy associated platelet factors, okay. Pregnancy associated placental growth factors, okay, that is PAP A. So that is also a marker of the double marker test, okay. I hope that is also clear. I am actually simultaneously seeing on the live chat, okay. Yeah, yes, pregnancy associated plasma protein A, that's exactly the word, yes, placental pregnancy associated plasma protein A. So remember, this plasma protein is actually coming from where? It's coming from placenta only. As we know, all the factors are always coming from the placenta. So it's pregnancy associated plasma protein factor, okay. Okay, so moving on, come to the question. Yeah, so I was telling this. So coming to the next, okay, so this is what? This is a systolic blood flow. And if you see, there is no diastolic blood flow. There is absolutely no diastolic blood flow. So what is it? Will be absent end diastolic velocity, okay. So जब diastolic end हो रहा है, end होते होते there is no flow in the diastole, okay. The baby is not getting any flow in the diastolic by the end. And if you see the third one, it's a reverse, okay. Actually now the scenario is very grave. This means कि instead of going from the mother to the baby, it's actually reverse. Diastolic में reverse हो रहा है, okay, in the umbilical artery. It's going from the baby to the mother. So of course it's a very grave situation. Reversed end diastolic velocity, okay. Remember this. So now coming back to the question. First of all, you need to identify कि problem क्या है इसमें, okay. What is the pathology? So now it's very easy. I hope that is, you can see there is no diastolic velocity. Reversal भी नहीं है और decreased भी नहीं है. So it's absent end diastolic velocity. Now when you have know that by diagnosis ये है, तो question is not that. Question is what will you manage? सो इट्स वेरी क्रूशियल कि आप पहले डायग्नोसिस सही बनाओ सो दैट द मैनेजमेंट इज ऑल्सो राइट. So let's discuss how do you manage a case of IUGR. Okay, so suspected IUGR is of less than 38 weeks. In IUGR, two important things are there. First of all, what is the period of gestation and what is the Doppler flow. Okay, so first is period of gestation if it is less than 38 weeks. Now if again has been broadly classified ki if it is less than 24 weeks or it is more than 24 weeks but less than 34 weeks. अभी लेस देन 24 वीक्स है. इमेजिन अ फीटल ग्रोथ जिसका लेस देन 24 वीक्स पे ही IUGR आ रहा है, तो यू अंडरस्टैंड कि वो प्रेगनेंसी बहुत कॉम्प्लिकेटेड होने वाली है क्योंकि जस्ट इट्स सो बिगनिंग एंड द बेबी इज IUGR एंड दैट इज़ वाई देयर इज नो सच गुड प्रोग्नोसिस. अगर आपको लग रहा है कि इवन मेटर्नल सिचुएशन इज health is deteriorating, then you will deliver. Okay, if you feel that there is a scope for improvement by the proper treatment and you have a good tertiary center ki around 28 weeks or 30 weeks also you deliver and the baby can be survive, then of course you will deliver the baby at NICU in a tertiary center and you will keep doing ultrasound every 3 to 4 weeks. Yeah, now if the baby is more than 24 weeks but less than 34 weeks, okay, now what you have to do, see every time the whole idea is in all pregnancy situations, चाहे IUGR हो, anemia हो, diabetes or anything, the main idea is two things: baby healthy, mother healthy, right? अगर mother को कोई problem होते हुए दिख रहा है in spite of any treatment, you deliver. अगर baby को कोई problem होते हुए दिख रहा है, you try to salvage the baby by at least crossing 34 weeks because तब lung maturity हो जाता है and then you deliver. This is a general concept for all the comorbidities of obstetrics. Okay, you try to deliver at least by 34 weeks because lungs maturity हो जाते हैं. And what do you give for lung maturity? Steroids. Okay, तो अभी आपका बेबी इज मोर देन 24 वीक्स बट लेस देन 34 वीक्स, तो आप क्या देखोगे? मदर का स्टेटस देखोगे कि हाउ इज द मदर डूइंग, हाउ डू यू सी द बेबी. बेबी का आप देखोगे डॉपलर से. तो अम्बिलिकल आर्टरी डॉपलर, एज आई टोल्ड यू, विल टेल अबाउट द बेबी. Fetal testing will be happening with the help of NST and biophysical profile. Remember, तो fetal surveillance या fetal monitoring की जब बात होती है तो 4 फैक्टर्स की बात होगी हमेशा. It will be growth patterns, बट जो ग्रोथ होती है that is done by head circumference furrow. It is done by head circumference, by biparietal diameter, by abdominal circumference and femoral length. Okay, these are the main growth parameters. Remember, ये ग्रोथ पैरामीटर्स बहुत फ्रीक्वेंटली नहीं करे जाते हैं क्योंकि बेबी को ग्रोथ का चेंजेस देखने में आपको टाइम लगेगा. सपोज आई एम टेलिंग इट इज़ 10 mm, तो अगर ये 10 का अगर कल ये 10.2 रीड करते हो आप, तो इट इज़ जस्ट कि इट इज़ ऑब्जर्विंग डिफरेंस, इट माइट बी एनीथिंग. सो दैट इज़ वाई जो ग्रोथ पैरामीटर्स होते हैं ऑलवेज दे आर मेजर्ड एटलीस्ट इन अ गैप ऑफ 3 to 4 weeks. ओके, रिमेंबर द ग्रोथ पैरामीटर्स. फीटल सर्वेलेंस के और क्या क्या फैक्टर्स होते हैं? फर्स्ट इज डॉपलर, अम्बिलिकल आर्टरी डॉपलर, विच कैन बी डन ट्वाइस अ वीक ऑल्सो और इवन अप टू डेली अगर डिपेंडिंग अपॉन सिवियरिटी. ऑल्सो फीटल टेस्टिंग, दैट इज NST, दैट इज नॉन स्ट्रेस टेस्ट एंड बायोफिजिकल प्रोफाइल, जो कि अगेन हम अल्ट्रासाउंड की हेल्प से करते हैं. तो फीटल मॉनिटरिंग 4 चीज़ें होती है: अम्बिलिकल डॉपलर, NST, बायोफिजिकल प्रोफाइल एंड ग्रोथ मॉनिटरिंग. जो फर्स्ट 3 मैंने बताए ये आप फ्रीक्वेंटली करते हो, दैट मीन्स इट कैन बी डन इवन ट्वाइस वीकली. ओके, रिमेंबर दैट. बट जो ग्रोथ पैरामीटर्स होते हैं वो दे टेक टाइम टू शो द चेंजेस एंड दैट इज़ वाई 3 to 4 weeks के बीच में ही होता है वो. ठीक है. नाउ अगर आपने देख लिया कि भाई अभी लेस देन 34 weeks है और अम्बिलिकल आर्टरी डॉपलर फीटल टेस्टिंग हाउ इट इज़ डूइंग, ऑफ कोर्स यू विल गिव फॉर लंग मेच्योरिटी स्टेरॉइड्स. ओके, फॉर अगर आपके पास एनी कोमॉर्बिडिटी का पेशेंट है you will always give steroids. Okay, preterm expected anemia है, diabetes है, IUGR है, twins है, always try to give steroids for a protection कि in case preterm delivery हो तो at least lung maturity of the baby is established. Now what you will do, consider delivery if only reverse of end diastolic flow is there. As I told you, systolic के साथ the reverse is happening. Okay, systolic के साथ reverse is happening. This is, I told you, a very grave situation and you have no option but to deliver. Of course, अगर fetal heart rate is not good or as I told you maternal condition is not good, in these 3 conditions you will deliver when the baby is less than 34 weeks. Okay, now suppose there are no such indications, mother baby are doing well, Doppler अच्छा चल रहा है आपका, तो आप क्या करोगे? You will do the surveillance, and surveillance I have told you what you will do, fetal testing you will do, Doppler you will do, weekly evaluation of amniotic fluid. Amniotic fluid, if you know, is a very part of biophysical profile only. एंड एज आई टोल्ड यू ग्रोथ के लिए एवरी 3 to 4 वीक्स आप करोगे. अब इफ यू आर सीइंग द बेबी इज ग्रोइंग नाइसली देन एटलीस्ट कंटिन्यू द प्रेगनेंसी टिल 34 वीक्स. If however any time you are seeing that the baby growth is not happening or any such of these three things they are getting hampered, baby ka fetal heart rate is not coming good, the Doppler is not coming good, then you will consider delivery. Okay. Now suppose the third scenario is now the POG has increased, now it is more than 34 weeks but less than 38 weeks. Now we are in a more safer zone. Okay, again we will see maternal status kaisa hai, baby ka status hum dekhenge by the Doppler, NST and biophysical profile. And now we will consider delivery only if it is absent or reverse. Okay, please remember absent or reverse end diastolic flow. Okay, so here we will not leave absent end diastolic flow, यानी कि अगर ये situation है. Okay, this means what, that this means that absent end diastolic flow is also not given a chance to continue in the pregnancy if it has crossed more than 34 weeks. Oligohydramnios है, non reassuring fetal heart rate है, maternal conditions कोई भी problem हो रही है, please consider delivery even if the baby is less than 38 weeks and you have already given steroid cover. Okay, so now I hope the question, if we see, you will be able to answer. अभी 28 weeks है. Okay, now the period of gestation we know is 28 weeks and what we have is absent end diastolic flow. Okay, absent end diastolic flow. So now I hope all of you will be able to answer. क्या करेंगे? Immediate termination of pregnancy, is it required? 28 weeks में absent end diastolic flow? No. Give steroid cover and monitor with Doppler and biophysical profile and plan delivery? Yes. Give steroid cover and take up for cesarean immediately? No. Go for normal vaginal delivery as baby is very small, so no. Okay, all these are wrong and I told you 28 weeks है, absent and diastolic flow है, you will continue the pregnancy till at least जो criteria we have discussed they are being fulfilled. Okay, now suppose there is a similar question. Okay, similar question. Now the placenta grade is 3. When they say grade का क्या significance है, basically the higher the grade, this means the maturity of the placenta is more and there is more of calcification. Basically the placenta is getting aged. Okay, it is not in a situation more to support the baby nutrition. तो ग्रेड 3 मतलब अगर आपको 35+3 पे ही दिख रहा है यानी कि प्लासेंटा इज़ नॉट हेल्दी. ओके, प्लासेंटा इज सिक. 35+3 वीक्स प्रेगनेंसी है एंड एब्सेंट एंड डायस्टोलिक फ्लो है. ओके, नाउ नथिंग हैज एक्चुअली चेंज्ड, ओनली द POG हैज चेंज्ड, सो दैट विल चेंज द फुल मैनेजमेंट. व्हाट विल बी द मैनेजमेंट नाउ? येस, यू विल नाउ talk with pediatrician and terminate. Okay, you will talk to the pediatrician and terminate. You will not give dexamethasone क्योंकि 34 weeks क्रॉस हो चुका है. Terminate after 37 weeks. You will not wait because absent and diastolic flow है after 34 weeks. Monitor and do nothing. Of course, this is also not the right answer. So you will talk with the pediatrician and you will terminate the pregnancy. Okay. Yeah. Now coming to the next question, and that is, what is the longest fetal diameter? Please remember, fetal pelvis के diameters and fetal fetal के structures के fetal skull के diameters, they are very direct questions. You have to memorize that because they are direct questions and very scoring. So just I'll help you to understand. It's very simple actually. If you start, if you see, when the baby is going down in the pelvis, okay, it goes down in a circular fashion. Remember, the fetal diameters, they can be divided into anteroposterior and transverse diameters. Transverse diameter, only one you have to remember, that is biparietal diameter. Okay, biparietal diameter is how much? 9.5 centimeters. So I have given already a hint कि anteroposterior diameter will be what? 9.5 centimeters. Why? Because I told you कि जो baby का head जाता है, as the way it engages, it is going to go in a circle. Okay, so circle means what? Full flexed head. Fully flexed head means the anteroposterior diameter should be same as biparietal diameter, that is 9.5. In a fully flexed head, remember, the diameter is going to be suboccipitobregmatic, behind the occiput. Okay, and bregma is nothing but the anterior fontanel, you all know. Okay, so anterior fontanel को हम bregma भी कहते हैं. तो सब occiput के नीचे से bregma तक का diameter कितना हुआ? 9.5 सेंटीमीटर्स हुआ. तो यानी कि अगर मैं देखूँ ट्रांसवर्स और AP diameter सेम हुआ तो it will engage as a circle. You can see as a circle. Okay, now if you see, थोड़ा सा मैंने deflex करा तो दो diameters can come. Either it can be occipitofrontal or it can be suboccipitofrontal. Basically ये एरिया आ जाएगा. फुली फ्लेक्शन में ब्रेगमा आता, इधर फिर फ्रंटल आएगा. तो सब ऑसिपिटो फ्रंटल या ऑसिपिटो फ्रंटल, ओके, लिटिल डिफ्लेक्शन में, तो ऑफकोर्स द डायमीटर्स विल इंक्रीज, दैट विल बिकम 10 सेंटीमीटर और 11.5 सेंटीमीटर्स, ओके, इट विल बी मोर देन 9.5, ओके। अभी इमेजिन करो ये माइल्ड एक्सटेंशन में गया, माइल्ड एक्सटेंशन मीन्स नाउ द ब्रो, इट्स अ ब्रो प्रेजेंटेशन, सो दे कैन आस्क यू दैट ऑल्सो कि ब्रो में प्रेजेंटेशन डायमीटर कौन सा होता है। Remember, it will be mento-vertical, okay, mento-vertical, vertical is again this highest point, okay, so this mento-vertical, you can see it is the longest fetal diameter, 14 centimeters bro में होता है, and that is the reason इतना बड़ा pelvic का कोई diameter नहीं होता, and this is the reason that brow does not have any mechanism of labor, okay, the brow is just stuck there, as soon as it goes into the pelvis it is just stuck, and of course cesarean ही करना पड़ता है to deliver this baby. Now coming to the fully extension, when fully extension means what is coming, now the phase presentation is coming. Fully extension में phase presentation हो रहा है, तो it will be submento-brachmatic diameter, okay, and ये कितना हुआ submento-brachmatic, it is again 9.5 centimeters, okay, so again it will be a circle, you start with 9.5 centimeters, you end with 9.5 centimeters, please remember, it's so simple to remember, okay, so but it will be submento-vertical, you start with suboccipito-brachmatic and you end with submento-vertical, but the dias are same, okay, और थोड़ा सा deflexed head हो जाएगा तो occipito-frontal में जाएगा, this is a deflexed head, and greater deflection means it's the brow, and the highest fetal diameter will go in this situation, okay, so it's very easy to remember but very important also. So I hope this answer is clear now. Longest fetal diameter will be what? Yes, it is mento-vertical, okay. Biparietal I told you is 9.5 centimeters, it's a transverse diameter. Suboccipito-brachmatic, it is going to be 9.5 centimeters. Occipito-frontal approximately 11 centimeters. Okay, now coming to the next question. Drug of choice for PPH which is resistant to oxytocin and ergometrin. Again a JIPMA question. Remember, the question is for resistant PPH resistant to oxytocin and ergometrin. तो read the question properly. PPH का प्रिवेंटिव मेजर्स अलग होते हैं एंड PPH के ट्रीटमेंट मेजर्स अलग होते हैं, ओके। PPH का प्रिवेंटिव मेजर इज मोस्ट कॉमनली इज द एक्टिव मैनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर। रिमेंबर, अगर PPH को प्रिवेंट करना है तो इट इज़ व्हाट, एक्टिव मैनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर, जिसमें हम क्या देते हैं 10 यूनिट्स ऑफ ऑक्सीटोसिन देते हैं. Sometimes if oxytocin is not there, then even methyl ergometrin can be given, provided there are no contraindications. Third line will be carboprost. Okay, in prevention as well as in treatment, it's the same order. Misoprost can also be given when other drugs are not available. The order is very important. Okay, the order is very important. The dosage we will learn gradually. Okay, remember, every woman in labor is at risk for PPH. 2/3 of those females actually don't have any identifiable causes. We know that in PPH the 4 T's you all know, right? Tone, trauma, tissue and thrombin. Okay, it's very simple, very easy to understand. Tone is the most common in this, and remember, if they ask you which is the most common reason for PPH and these options are not there but a mismanaged third stage of labor is there, then remember that is going to be the answer, because a good management of third stage of labor will prevent 60% of atonic PPH, and all postpartum females should be monitored closely for PPH. There are few updates also I would like to share, because before we know कि vaginal birth के लिए हमने कहा था कि at least 500 ml से ज़्यादा bleeding होगा, then we label it as PPH, और cesarean में more than 1000. But now it is that it should be more than 1000 irrespective of mode of delivery. Okay, so अगर जब तक 1000 cross नहीं हो जाता irrespective of mode of delivery, we don't call that as PPH. Questions have also been asked, what is primary PPH and what is secondary PPH? Primary PPH means within 24 hours and secondary means after 24 hours up to 12 weeks. Previously it was 6 weeks, but this again has been changed to 12 weeks. Okay, so these are a few updates. Coming to a brief discussion of treatment protocol of atonic PPH only, I'll discuss. So we know that management of shock has to be done by the ABC protocol, and then you manage the atonicity. The atonicity, okay, so someone is asking PPH, it's postpartum hemorrhage, dear. Postpartum hemorrhage, okay? Postpartum, okay? Partum means delivery, remember. Postpartum, partum, the word partum means delivery. So antepartum, will they say antepartum? This means she is right now pregnant, okay? Postpartum means just now only she has delivered. And when I say intrapartum, this means उसकी delivery हो रही है. She is undergoing the delivery right now. Okay. So antepartum, intrapartum and postpartum. Okay. Fine. So and postpartum hemorrhage means कि delivery के बाद उसको bleeding हो रही है बहुत ज़्यादा. And कितना bleeding हो रहा है? That's what I told you, more than 1000 ml. तब उस patient को आप PPH label करते हो. Okay. So how do you manage this? We are discussing that. So there will be conservative medical management and surgical management. Surgical management will be conservative and radical. Conservative means you will try to preserve the uterus. Radical means you will remove the uterus. So conservative surgical approach में हम देखते हैं तो manual removal of placenta, exploration of uterus, uterine packing. See, the whole idea of managing atonic PPH is that you have to give tone to the uterus. And how do you do that? कोई भी एक मसल लूज हो गई है तो आप उसको प्रेस कर दोगे. हमारे भी चोट लगती है तो हम क्या करते हैं, यहाँ पे प्रेस कर देते हैं, दबा देते हैं. वही हमें यूट्रस के साथ करना है. वी हैव टू प्रेस द यूट्रस. और क्योंकि ब्लीडिंग अंदर से हो रही है इसलिए हमें अंदर स्टफिंग कर देनी है. जो भी मिले हमको, हम पैकिंग कर सकते हैं, हम फोलिस कैथेटर के बलून को इन्फ्लेट कर सकते हैं. देयर आर सम स्पेशलाइज्ड बलून्स विच आर मेड फॉर PPH. ओके, वील डिस्कस दैट ग्रेजुअली, जिनको हम सेंस टेकन ब्लैकमेल ट्यूब भी बोलते हैं. Yeah, so Suraj is asking, can you explain intrapartum? Intrapartum means the patient is undergoing delivery. Okay, so delivery के जब हम we'll study gradually all the stages of labor, first, second and third. That time that labor patient जो बोल रहे हैं ना, patient labor में है, patient delivery हो रही है उसकी, that is called as intrapartum. Okay, so before she is in labor, antepartum, intrapartum, and after delivery of course the baby, it is called as postpartum. Okay. So these are the tamponades. Okay, tamponades मतलब pressure effect हम दे रहे हैं यूट्रस के अंदर, so that जो bleeding हो रही है वो रुक जाए. Okay, फिर next step we move on to stepwise devascularization. Then there are some compression sutures which we will see. Then there is artery ligation and finally postpartum arterial embolization. So let's have a look at this. So for discussing this slide I'll have to revise a little of your anatomy. देखिए, जो aorta होता है, aorta we know it will divide into two common iliac arteries at the level of L4. These two common iliac arteries further divide into internal iliac and external iliac. Okay, external iliac and internal iliac will give total 8 branches. 5 anterior branches देती है और 3 posterior branches देती है. The most important branch is uterine artery. Uterine artery is a branch of the anterior branch of the internal iliac artery. अभी आपको मालूम है कि यूट्रस पे सारा ब्लड सप्लाई यूट्राइन आर्टरी से आ रहा है, तो ब्लीडिंग रोकने के लिए क्या करना चाहिए? वी विल लाइगेट द यूट्राइन आर्टरी ऑफ कोर्स. तो वी विल एक साइड का यूट्राइन आर्टरी बांध दो, फिर दूसरी साइड का भी यूट्राइन आर्टरी बांध दो. अभी क्या होता है, ड्यूरिंग प्रेगनेंसी द यूट्रस इज वेरी वेरी वैस्कुलर. दिस मीन्स दैट इवन फ्रॉम द ovarian artery it is getting the blood supply. Abhi ovarian artery is a branch of from where? Ovarian artery, remember, is a direct branch from aorta. तो अभी क्या होता है, यूट्राइन आर्टरी और ओवेरियन आर्टरी के बीच में इनास्टोमोसिस काफ़ी अच्छा हो जाता है. यूट्रस बिकम्स अ वेरी रिच वैस्कुलर ऑर्गन. तो अगर आपने यूट्राइन आर्टरी दोनों साइड बांध दी, उसके बाद भी डिस्पाइट दैट ब्लीडिंग इज हैपनिंग, द नेक्स्ट स्टेप विल बी यू विल हैव टू लाइगेशन ऑफ द यूट्रो ओवेरियन आर्टरी. दैट इज द इनास्टोमोसिस हो रहा है एक साइड पे, फिर दूसरे साइड पे इनको बंद कर देना है. इसी को बोलते हैं हम स्टेप वाइज डीवैस्कुलराइजेशन कर रहे हैं. ओके, स्टेप वाइज डीवैस्कुलराइजेशन. Now what is this? They can ask you simply, they can give you this image and they can ask you any question. So remember, this is B-Lynch suture and it is a compression suture. As I told you, these are the compression sutures. कि भाई आप पहले ये suture लगाने से पहले आप यूट्रस को हाथ से you manually compress the uterus and you check for कि whether the bleeding has stopped or not. If it is stopping, only then there is an advantage of giving the suture. So as you can see, basically 2 loops are being put on the uterus to compress it, and you can see uterus compress हो चुका है. Okay, so this they can put you as image and they can ask you question. This is another square sutures. Okay, you can see square have been made. Okay, this is known as Cho sutures. Please remember. Okay, this is known as Cho sutures. These are again the compression sutures. The whole idea is to compress the uterus. Okay, to stop the bleeding. Yeah, now what is this? I know in this you can say मैम इसमें तो फाइब्रॉइड दिखा रहे हैं. I know फाइब्रॉइड तो दिखा रहे हैं, but then this technique is used to decrease the blood supply to the uterus. The whole idea is to decrease the bleeding which can be happening in fibroids or in postpartum hemorrhage. अभी the anatomy which I told you excuse me, या सो द एनाटमी आई टोल्ड यू, मैंने बताया कि जो कॉमन इलियाक होता है इट डिवाइड्स इनटू इंटरनल इलियाक एंड एक्सटर्नल इलियाक. आई होप यू कैन सी दैट. अभी एक्सटर्नल इलियाक चेंजेस द नेम टू फेमरल आर्टरी. ओके, फेमरल आर्टरी बिलो द इंग्वाइनल लिगामेंट. होप यू रिमेंबर दिस एनाटमी. तो अभी क्या करना है हमको, फेमरल आर्टरी इज ईजिली एक्सेसिबल, तो फेमरल आर्टरी के थ्रू हम जाएंगे और हम इप्सीलैटरल एंड कॉन्ट्रालैटरल इंटरनल इलियाक आर्टरी की यूट्राइन आर्टरी तक पहुंचेंगे और वहाँ पे एम्बोलाई छोड़ देंगे. एम्बोलाई मीन्स देयर आर सम केमिकल्स विच आर रिलीज्ड to decrease the, to which actually block the uterine artery, and of course the blood supply to the uterus will be lost. That is the whole idea. Okay, and this is known as arterial embolization. Okay, arterial embolization. तो remember, हमें एक प्रिक से ही दोनों वेसल्स को हम ब्लॉक कर सकते हैं, दो प्रिक्स की ज़रूरत नहीं है. विद अ सिंगल प्रिक वी कैन डू दिस. Okay, so this is a brief description I have done of the PPH or the postpartum hemorrhage. So the answer for that question will be drug of choice for PPH resistant to Synto and ergometrin medical management. I told you the third will be carboprost. Okay, yeah. Coming to the next question. Now there's a G6 plus 0 lady with history of recurrent missed abortions at 14 to 16 weeks comes to you with missed abortion at 12 weeks. Which is of the following is not warranted? तो फर्स्ट ऑफ ऑल आई होप यू अंडरस्टैंड ऑल व्हाट इज़ दिस, ये क्या लिखा होता है उसको समझना बहुत ज़रूरी है. G6 plus 0. ओके, सो रिमेंबर ग्रेविडा. व्हाट इज़ ग्रेविडा? प्लीज अंडरस्टैंड दिस कॉन्सेप्ट्स बिकॉज उसके बिना यू मे गेट द क्वेश्चन रॉन्ग ऑल्सो. ग्रेविडा मीन्स नंबर ऑफ टाइम्स द पेशेंट हैज़ कंसीव्ड. ये हम सबको मालूम है, बट दिस इज इनकम्प्लीट डेफिनेशन. ओके, gravida means the number of times she has conceived irrespective of the mode of termination of pregnancy. I'll repeat, gravida means the number of times she has conceived irrespective of the mode of termination of pregnancy. This means इसमें term, preterm, abortion, stillbirth, IUD और ectopic और HMOL, ये सब आएगा इसके अंदर. अगर वो ectopic हुआ है उसको 3 तो she will be G3. मतलब ग्रेविडा मीन्स, और ऑफकोर्स इट इज़ इंक्लूडिंग द प्रेजेंट प्रेगनेंसी ऑल्सो. अगर उसको प्रीवियस टू एक्टोपिक हुए हैं, एचमोल हुआ है, वो सब ग्रेविडा के अंदर काउंट होएगा, उसका स्कोर बढ़ता जाएगा. व्हाट इज पैरिटी मीन्स? पैरिटी मीन्स हाउ मेनी टाइम्स दैट प्रेगनेंसी हैज़ क्रॉस द पीरियड ऑफ वायबिलिटी एक्सक्लूडिंग द प्रेजेंट प्रेगनेंसी. दिस इज़ वेरी इंपॉर्टेंट. ओके, so I hope this definition should be very very clear to you. So when you say G6 plus 0, okay, so there's a way in which some they prescribe like this. T-pal, you remember as T-pal. So T means term, P means preterm, A means इतने abortion हुए हैं, and L means कि इतने live babies हैं उसके पास. ठीक है. A point to mention over here is also remember that twins में ग्रेविडा और पैरिटी नहीं चेंज होते हैं, सिर्फ लाइव नंबर ऑफ बर्थ्स चेंज होता है. रिमेंबर दैट. ओके, देयर हैज़ बीन क्वेश्चंस आस्क्ड फॉर ट्विंस से ग्रेविडा और पैरिटी कैसे चेंज होता है. दे डोंट चेंज, लाइव बर्थ केवल चेंज होता है. ठीक है. अभी नाउ व्हेन यू से G6 plus 0 दिस मीन्स शी हैज़ बीन प्रेगनेंट बट उसको अबॉर्शंस हुए हैं. ओके, एंड हिस्ट्री ऑफ रेकरेंट मिस्ड अबॉर्शंस हुए हैं उसको एट 14 to 16 वीक्स. पहले वो बता रहे कि उसको बहुत सारे रेकरेंट मिस्ड अबॉर्शंस हुए हैं. नाउ व्हाट इज रेकरेंट मिस्ड अबॉर्शन मीन्स? इट स्ट्रिक्टली स्पीकिंग इट इज़ मोर देन 3 मिस्ड अबॉर्शंस, 3 अबॉर्शंस, बट कॉन्जिक्यूटिवली, ये वर्ड इंपॉर्टेंट है, कॉन्जिक्यूटिवली उसको 3 अबॉर्शंस लॉस हुए, 3 अबॉर्शंस हुए हैं. अभी एट 14 to 16 वीक्स कम्स टू यू विद अ मिस्ड अबॉर्शन एट 12 वीक्स. अभी फिर से मिस्ड अबॉर्शन है उसको 12 वीक्स पे. अभी इसमें से कौन सा टेस्ट यू विल नॉट डू? ल्यूपस एंटीकोगुलेंट, एंटीकार्डियोलिपिन एंटीबॉडीज, VDRL, fetal karyotype. Okay, so this is very important, and brief discussion of RPL we'll do over here. Let's see the causes. The most common causes are chromosomal abnormalities, we know, and this will be the first trimester में commonly chromosomal abnormalities होती है. Balanced Robertsonian translocations is more than aneuploidy. Okay, remember this one. ये पेरेंट्स में होता है. पेरेंट्स में अगर बैलेंस्ड रॉबर्ट्सोनियन ट्रांसलोकेशन होता है, दिस विल बी अ मोर कॉमन फैक्टर for causing abortions as compared to aneuploidy. Okay, if they ask you, now the question is asking which of the following is the most common cause of RPL as a group means endocrinopathies उन्होंने पुट कर दिया. अभी endocrinopathy इसमें थायराइड भी आ गया, PCO भी आ गया, डायबिटीज़ भी आ गया, ये सब आ गया. तो ऑफकोर्स दिस विल बी द आंसर. सेकेंड विल बी द यूट्राइन एबनॉर्मैलिटीज़. ऑफ कोर्स वी नो द सर्वाइकल इनकॉम्पिटेंसी ये सब इंक्लूड करके प्लस द यूट्राइन के जो सारे सेप्टम बाइकॉर्नुमेट ये सब होते हैं, दैट विल बी द सेकेंड कॉज एज ग्रुप्स. उसके बाद इम्यूनोलॉजिकल फैक्टर्स आ जाते हैं, उसके बाद क्रोमोसोमल आते हैं. तो दीज आर द वे इफ इट इज आस्क्ड एज ग्रुप. But if it is asking is as individual, suppose the option is saying thyroid, number 1, second is PCOS, third is APLA. Okay, the APLA is, we know it's an immunological group. Okay, so as a group, immunological factors third पर है, but as individual, APLA is the number 1 for the cause of RPL. Please remember that. Okay, and remember infections, torch. It has been very much proven torch या कोई भी और infections, they don't cause recurrent pregnancy loss. Okay, they don't cause recurrent pregnancy loss. So in this case if you see that VDRL of mother and father, VDRL भी known as for syphilis, तो syphilis जो होता है वो recurrent pregnancy loss नहीं cause करेगा. Lupus anticoagulant, anticardiolipin antibodies, they are for APLA. Fetal karyotyping of course you will do because जो Robertsonian translocations होते हैं they are kind of recurrent and they will affect the fetal karyotyping also. So that means answer will be VDRL. Okay, coming to the next question, which of the following is false? Okay, so this is a question on MTP. I specially put a question on MTP because recently there have been updates about it. तो इसमें गलत क्या है? MTP more than 12 weeks requires opinion of 2 RMPs, more than 20 weeks require opinion of 2 RMPs. Ultrasound is not mandatory for early pregnancy. MTP, the pressure created in MBBS syringe is 600 milliliter of mercury. I hope you all know what is MBBS syringe. It is manual vacuum एस्पिरेशन सिरिंज. ओके, सो बेसिकली एक रॉ वर्ड्स में बोला जाए इट्स अ बिग सिरिंज. 60 ml इसकी कैपेसिटी होती है, 60 ml. ओके, इट्स अ बिग सिरिंज एंड यू नो पुल इट, यू क्रिएट अ वैक्यूम और उसके बाद दैट वैक्यूम मतलब यू देयर इज अ कैनुलास ऑल्सो. You put those cannulas in the uterus and then you release the vacuum. तो क्या होता है एकदम से vacuum release होता है तो सब सक कर लेता है वो यूट्रस के अंदर जो भी होता है. So the pressure is very very good. It is 600 millimeter of mercury. So it's a very nice thing and the good things is कि ये पेरिफेरीज में यूज़ हो सकता है. इसमें प्लास्टिक कैनुलास होते हैं तो रिस्क ऑफ परफोरेशंस वगैरह बहुत कम होता है, ऑलमोस्ट ज़ीरो. And the pressure creation is very good. It is not dependent on that central vacuum machines या anything पे. Manually it can be done. Okay. So ultrasound is not mandatory for early pregnancy. Remember that is a true statement. So अभी इन दोनों में हमें डाउट है तो मैंने यही बोला that what is the new update is that MTP more than 20 weeks requires opinion of 2 RMP. This is the right answer. ये पहले सही था कि 12 weeks से ज़्यादा है तो opinion of 2 RMP is required, but it has been modified. You should know these modifications. Okay. So first of all we know what is the it is a new law which is come in 2021. The new law says that the gestation age limit for abortions has been raised from the earlier ceiling of 20 weeks to 24 weeks. Okay, but only for special categories requiring approval of 2 registered doctors. ठीक है, all pregnancy up to 20 weeks require only 1 doctor's approval. Second is pregnant women can now terminate unwanted pregnancies regardless of their marital status, because you see lot of females we are seeing who are unmarried and who are conceiving and they come for this thing. So they we get the most common reason for that is contraceptive failure. So regardless of their marital status they have the right to undergo abortion. Also the third new point is there is no upper gestation limit for abortion in case of fetal disability if so decided by a medical board. Okay, तो अगर आपके पास कोई पेशेंट 26-28 वीक्स पे आ रही है तो आप उसको मना नहीं कर सकते हो. देयर इज़ अ स्पेशल टीम जो बैठती है मेडिकल बोर्ड की और विच स्टेट गवर्नमेंट्स या कोई और भी सेटअप कर सकता है एंड देन दे विल डिसाइड दैट अगर फीटल वायबिलिटी ही नहीं है देन ऑफकोर्स द पेशेंट कैन अंडरगो अबॉर्शन. ओके, the next is no registered medical practitioner shall reveal the name and other particulars of a woman whose pregnancy has been terminated under this act. So of course strict privacy of the patient has to be kept. So I hope this answer is clear and the new amendments are also clear to you. Moving on to the next question. Now there is G2P1 female with 7 weeks pregnancy with UPT. Okay, on TVS nothing is seen. What is TVS? Transvaginal sonography. अभी G2P1 क्या हुआ? As I told you कि ये सेकेंड टाइम प्रेग्नेंट है और पहले की प्रेगनेंसी में इसकी प्रेगनेंसी इन द पहली वाली जो बिफोर प्रेगनेंसी दैट हैज़ क्रॉस द पीरियड ऑफ वायबिलिटी. बट अगर मैं सपोज G2P1L1 लिखूँ दिस मीन्स दैट बेबी इज़ अलाइव. जो पिछली वाली प्रेगनेंसी का बेबी जो क्रॉस कर गया था वो लाइव है. और अगर मैं लिखूँ G2P1L0 दिस मीन्स जो पिछली वाली प्रेगनेंसी का बेबी डिलीवर हुआ था वो लाइव नहीं है एंड शी सेकेंड टाइम प्रेगनेंट. ओके, so this means G2P1L1 and G2P1L0. Behral, we are not concerned regarding that because the question is related to the present pregnancy. Now she is 7 weeks pregnancy with UPT positive. TVS में क्या होता है? Remember, TVS normally will show that the baby fetal cardiac activity as early as 5 to 6 weeks. Okay, as early as 5 to 6 weeks. But then there are certain criteria. You will see that. Abhi the question is asking what is the next step in management. So yes, what will you do? Yes, tell me. See, UPT you have done, okay, UPT you have done, and the second step is always doing TVS. okay. Now there can be 3 things. आपने स्कैन करा, 3 things हो सकते हैं. या तो आपको इंट्रा यूट्राइन ही जी सैक दिख गया, okay, that is good enough. That means a true gestational sac is there. But remember, only a gestational sac in the uterus does not confirm that it is a intrauterine pregnancy. Okay, remember. Yolk sac should be present. Yolk sac जब तक present नहीं होगा, we don't confirm it as intrauterine pregnancy. Remember, that can also be MCQ. Also know that pseudo gestational sac can be present when you have a doubt. जब आपको yolk sac नहीं दिख रहा है, जब yolk sac दिख गया तो 100% it is a true gestational sac. जब तक yolk sac नहीं दिख रहा, it can be a pseudo gestational sac also. अभी उसके बाद आपने स्कैन करा तो आपको इंट्रा यूट्राइन या एक्स्ट्रा यूट्राइन कुछ भी नहीं दिखा, जेस्टेशनल सैक इज एब्सेंट. थर्ड, आपने देखा कि एक्स्ट्रा यूट्राइन जेस्टेशनल सैक इज प्रेजेंट, तो दैट विल कंफर्म द एक्टोपिक प्रेगनेंसी. अब इफ समथिंग इज सीन इन द यूट्रस, यू आर श्योर व्हाट टू डू. इफ समथिंग इज सीन आउटसाइड द यूट्रस, यू आर श्योर व्हाट टू डू. बट इफ नथिंग इज सीन, if the scan is showing you nothing but the UPT is positive, then what you will do? That is the trick over here. Okay, so 3 differential diagnoses of empty uterus are there. Okay, first it can be abortion, it can be ectopic, or it can be early intrauterine pregnancy. Remember, when you are seeing nothing on the scan, these are the 3 differential diagnoses. So how will you differentiate? Simple next step is beta HCG. You will do the beta HCG, and you should know that critical titer for TVS is 1500 units minimum. This means कि जब मैंने बीटा HCG कराया उसका अगर 1500 यूनिट्स नंबर आया है तो मुझे TVS पे 100% जेस्टेशनल सैक दिखना चाहिए. या फिर if it is the number is coming of beta HCG as 5000 and I am doing a trans-abdominal scan, then I should be seeing a gestational sac on trans-abdominal sonography, as simple as that. Okay, critical titer ये है. If the value is less than critical titer, then what you will do? If it is more than, तो भाई we should expect at least this much. Okay, fine. But if it is less than this much, less than the critical titer, then what you will do? So remember, if beta HCG is less than 1500, we are seeing TVS only because it has become a standard. Okay, nowadays early pregnancy everyone will do TVS only. So beta HCG is 1500 units. What you will do? The next important thing is repeat after 48 hours. Repeat after 48 hours. Grossly speaking, it will double. Grossly speaking, to be very accurate, it will increase by 66%. In a normal pregnancy, intrauterine pregnancy, it will double. That means 66% से increase होएगा. अभी ये increase हुआ by 66%, तो ये है. लेकिन ये increase तो हुआ, लेकिन 66% से नहीं हुआ. Okay, it didn't increase by 66%. This means it's an ectopic pregnancy. Please remember that. Okay. Suppose the value has increased nicely by 66. It is intrauterine, it is increased but less value, it will be ectopic. And if it is decreased, then it will be abortion. Okay, so this is a full standardized way how you diagnose a pregnancy. Okay, and of course if the beta HCG is more than 1500 units and you don't see anything in the uterus, it is of course ectopic pregnancy. क्योंकि इतने लेवल पे आपको यूट्रस के अंदर एक वायबल प्रेगनेंसी दिख जानी चाहिए थी, but you are not seeing it. Okay, so I hope this answered this question that G2P1 7 weeks pregnant है, UPT positive है, TVS में कुछ नहीं दिख रहा. What you will do? The next step is beta HCG levels. Serum progesterone, actually strictly speaking no one does it in pregnancy अभी, except of course IVF pregnancies होती हैं. तो Caldocentesis we know it is the aspiration of fluid from the pouch of Douglas. It is reserved only for ectopic pregnancies. वो भी पहले होता था, we don't do it now. Repeat TVS after 10 days. We don't usually wait for 10 days. We will repeat the beta HCG. Yeah, so coming to the next question now, 9th question. A 30-year female with the previous one child underwent DNA of a complete male, which was confirmed on histology. After 8 weeks, her beta HCG is 20,000 international units. what is the most appropriate management? Okay, so remember, previous one child, okay, underwent DNA of a complete mole, which was confirmed. After 8 weeks, her beta HCG is 20,000 units. So this means she had one normal pregnancy, para one, live one. After that, she has a H mole, right? That is what it's saying. H mole के लिए she underwent DNA. Okay, when she was on a follow-up, after 8 weeks, her beta HCG is still 20,000 units. What will you do next? Okay, so if anyone wants to answer, please answer. Combined chemo, IM methotrexate, hysterectomy, repeat DNA. Yes. So before you answer this question, you need to know a little about this table, not the full, but at least little. Okay, age is very important. Previous pregnancy. Remember, the score will जितना high होएगा उतना खराब आपका GTD यानी कि gestational trophoblastic disease या H moles का prognosis होएगा, जितना ज़्यादा score होएगा. ओके, तो अगर टर्म प्रेगनेंसी के बाद आपको एक एच मोल हो रहा है, आपको हाइड्रोफॉर्म मोल आफ्टर एक टर्म प्रेगनेंसी के बाद हो रहा है, दिस इज़ अ बैड न्यूज़. ओके, टर्म प्रेगनेंसी विल गिव यू मोर स्कोर एंड इंटरवल जितना ज़्यादा होएगा उतना ही ख़राब है, क्योंकि कम गैप होएगा तो हो सकता है कि भाई ठीक है, इट वॉज अ माइल्ड डिजीज़, बट मेजर डिजीज़ वो होगी जो एक अबॉर्शन या टर्म प्रेगनेंसी या मोल कुछ भी होने के बाद भी अभी तक आपकी वैल्यू ज़्यादा दे रही है. ठीक है, तो इंटरवल बिटवीन इंडेक्स प्रेगनेंसी एंड कीमोथेरेपी जितना ज़्यादा होएगा उतना स्कोर खराब होएगा. प्री ट्रीटमेंट बीटा HCG लेस देन 1000, 1000 to 10,000, 10,000 to 1 lakh, and then you have 1 lakh and then more than 1 lakh of course. So in this patient we know that उसका कितना आया था, 20,000 units आया था. So she'll be in this unit class. Okay, at least these 4 you are expected to know. Okay, others जितना याद हो उतना अच्छा है, but at least these 4 are important. So coming to this patient, she is 30, right? So how much score you will give? 30 means she will be 0 score in this. Okay, with previous one child underwent DNA of a complete mole, यानी कि previous उसकी term pregnancy है, तो उसका यहाँ पे 2 हो गया, right? तो 0 plus 2, age ये antecedent, interval between index pregnancy and chemotherapy, at least इसका 8 weeks है. Okay, after 8 weeks it is 20,000. So 8 weeks means she will be in this range. So plus 1, and pre-treatment beta HCG is 20,000. So she will be plus 2. Okay. So total score is approximately less than 6. और अगर किसी भी patient का 6 या less than 6 है, she has a good prognosis, and the treatment will be simple methotrexate. Okay. If this whole score, again if you calculate for any patient and it is coming for more than 7, then it is a poor prognosis, and this is a multiple chemotherapy. Okay, multiple chemotherapy, multiple drugs have to be given, and this means of course a poor prognosis is there. Okay, so this table is very important. Suppose a similar question is there, and now the female is 40 years, irregular cycles for 7 months after her delivery of her 4th baby, curettage is performed, and her HP is showing choriocarcinoma, beta HCG level is 2 lakhs. Okay, so what will be the management? So if you see again, so age is 40. Okay, age is 40, antecedent pregnancy is term, interval if you see was 8 months. Okay, and the value of beta HCG is more than 1 lakh. So 1 plus 2 plus 2 plus 3, 3 plus 2 5, 5 into 7, the value is 8, right? So she is now coming into a poor prognosis, and what will be the treatment? With combined chemotherapy. But remember, as you can again calculate, okay, so treatment with combined chemotherapy will be the best option for this female. Of course, if she is not willing for all such things, she can also undergo hysterectomy, but then if the patient is willing, the ideal treatment is treatment with combined chemotherapy. So it's very important to know at least these 4 rows you have to memorize, so that you can take out the scoring, and then you will decide the management of the patient. Coming to the 10th question, a female with 36-week gestation with hypertension, blurring of vision and headache, her BP is 180 by 120, and after 20 minutes इतना BP है 174 by 110. How will you manage this patient? तो again, अगर management करना है तो पहले we need to diagnose the patient. What is the diagnosis? 36 weeks है, hypertension है, blurring of vision है, headache है, ठीक है, BP इस इतना है और 20 minutes बाद इतना है. तो what is the main diagnosis? First you have to tell me, ठीक है. So the diagnosis is severe preeclampsia. Okay, so we know what is preeclampsia. Preeclampsia means BP high है plus proteinuria. Okay, but if there is any end organ damage, any end organ damage is there, जैसे कि headache हो रहा है, blurring of vision है, dyspnea है, kidney problem हो रहा है, oliguria हो रहा है, any such problem is there, this means there is end organ damage. And that time, end organ damage, that time you will give it as severe preeclampsia. The diagnosis is severe preeclampsia. Okay, now we should know what is the management of severe preeclampsia. Okay, so these are the clinical parameters to differentiate between mild and severe. Remember, preeclampsia can be only two, mild and severe, it's not moderate. Okay, so systolic BP 140 to 160. If it is more than 160, severe. Diastolic blood pressure more than 110, severe. Headache, visual disturbances, any such things, this means severe hoga. Preeclampsia. Laboratory parameters, urinary output, if it is oliguria, very much high protein. Proteinuria means preeclampsia, but if it is the amount, if it is more than 5 grams or on urine dipstick, it is 3 plus or 4 plus, this means it is severe preeclampsia. Okay, now how do you management? I don't know whether this table is clear or not, but remember, first of all, these patients have to be hospitalized. Okay, any severe preeclampsia patient has to be hospitalized, and all the laboratory tests means CBC, LFT, RFT, these are the very important, and then one optic fundal study. Okay, these are very essential. Of course, urine protein is also there. Okay, now after stabilizing the patient, if the patient is more than 34 weeks, okay, if the patient is more than 34 weeks and she is hemodynamically stable, then you can, and the baby is also hemodynamically, the baby is also growing nicely, there is no IUGR, there is no oligo, the factors which I have discussed Abhi in the last question. If those are not there, then of course you can continue the pregnancy. If at all there is a problem to progression to severe disease, okay, the patient throws fits, or despite the treatment, that is antihypertensives you're giving magnesium sulfate, despite that the patient BP is not getting controlled, she's still getting end organ failures, then you will definitely terminate the pregnancy. Okay, that is the whole idea. Now, indications of termination in preeclampsia irrespective of gestational age. Just now I told you that if all these factors, if impending eclampsia, HELP, abruptio, pre-viable fetus is compromised, uncontrolled BP despite treatment, and there is reverse end-diastolic flow. Okay, all such things if you are getting, then you will just terminate the pregnancy irrespective of the period of gestation. Now suppose the question is asking, 27 years female is there with PIH, her BP is 150 by 100, okay. At 32 weeks, there is no other complaint. Her BP is controlled on medications, no other complication. Now when you will terminate this pregnancy, okay. Now first of all, what is the diagnosis? Is she having any end organ failure? Besides proteinuria and hypertension? No, she is having no other complaints. Of course, you will do all the blood laboratory tests. So the routine management will be antihypertensive as OPD patient and termination via vaginal at 37 weeks. Okay. So preeclampsia per se is not an indication for cesarean. Remember that. You have to see the obstetric factors also. If they are also not supportive, then you will take for cesarean. Otherwise, vaginal delivery can also be considered. The answer will be 37 weeks. Next question. Identify the type of twin. Okay, so always remember twinning questions. This is a favorite which has been asked. So just a brief revision. Remember, twins means they can be two. Okay, monochorionic or dichorionic. Okay. See, dichorionic simply means that there is chorionicity means placenta. Monochorionic means one placenta will be there. Okay, and dichorionic means two placenta will be there. Simple. Okay. Now monochorionic, when there is one placenta, there can be either two amniotic sacs or one amniotic sac. Okay, so monoamniotic or diamniotic. In dichorionic, always there will be two amniotic sacs, so it will be diamniotic, dichorionic always. With dichorionicity, there can never be one amniotic sac. Okay, so monochorionic, monoamniotic and diamniotic. And which is the most complicated pregnancy out of all this? Monoamniotic, monochorionic. Okay, remember that. Now the question is asking that what is the picture showing. If you see, you can make out two gestational sacs are there. So this, you know, it is twins. Okay, now you need to see this line, right? So if you can make out, see, this is a placenta. Okay, this is a placenta and this is growing in between the gestational sacs. It's actually the chorion. Okay, the chorion villi grow in between the two gestational sacs, and that is known as what sign on scanning? This is a question. Yes, what it will be, please tell. Yeah, so it's a twin peak sign or the lambda sign. Please remember. Okay, so it's basically a peak sign. Okay, a peak sign. Remember that. So it is a typical of diamniotic dichorionic. As I told you, in dichorionic always it will be diamniotic. However, if it is monochorionic, monochorionic means monoamniotic or diamniotic it can be there. Abhi monoamniotic means there is going to be nothing, there is going to be no membrane between the two babies, okay? They are like in the same room, they are there. So of course it's a most complicated pregnancy. When I talk about diamniotic, so it's a very single membrane, thin membrane, okay? And that is why it is known as T sign, okay? Remember, T sign. T sign they ask, it will be diamniotic monochorionic, but if it is lambda sign or T sign, twin peak sign, it is 4 membranes, that is amnion, chorion membrane of one baby and chorion amnion of the other baby. So 4 membranes, okay? T sign will be only 2 membranes, that is 2 amniotic membranes. The thickness will be more than 2 mm over here, of course. The thickness will be less than 2 mm in this scenario, okay? So remember, this is a very, pet question of most of the examiners for twins. Remember that. So as I told you, if you see over here, it's a very thin line. So it's a T sign. It's a thick line. You can see the placenta basically growing inside. It is a lambda sign. It is showing the dichorionic twins over here. And monochorionic means T sign will be there. Yeah. So next question is Rh negative pregnancy, G4P3. Okay. So she's pregnant right now. She previously had 3 pregnancy which crossed the period of viability. Her antibody level is 15 international units. Okay. And her Coombs test, indirect Coombs test was done, which is showing that 1:32 is the ratio at 27 weeks. What is the most appropriate next step in management? Now, Rh negative, of course, we will touch upon only the question. We will not go into much detail. But remember, if the ICT, that is, ICT means simply what? The antibodies which the mother has in her blood, which can kill the fetal RBCs. I'll repeat it. ICT means the amount of antibodies the mother has in her blood which can kill the fetal RBCs. Of course, the mother is Rh negative and the baby is Rh positive. Okay. So this mother has developed antibodies against Rh factor which will go and hemolysis of the fetal RBCs will happen, and that is why the main complication of Rh negative mothers is fetal anemia. Okay. There's a full spectrum of fetal anemia which can happen. But we are concerned that now we have seen a 15 antibody level of 15 is there. Okay, usually an antibody level of more than 10 means it is a harmful critical titer. Critical titer means the amount of antibody is sufficient enough to kill the cells. Okay, so in this scenario it is crossed that. Okay, so this means we know patient is having sufficient antibodies who can kill the RBCs of the baby. So what you will do in the next step? Okay, so establish the amniotic fluid bilirubin level. This is, if you remember, it is done by the Lilly's chart. Okay, Lilly's chart. Estimate the fetal hemoglobin by quadrocentesis. Estimate the MCA PSV. Perform the intrauterine transfusion. So as soon as I know that antibodies का level इतना है, तो मुझे fetal monitoring करनी है. सबसे पहले fetal monitoring में I will see for the signs by the ultrasound how much anemia is coming and how do I do that. In today's scenario, I told you because of the Doppler facility we have, everything is mostly told by the Doppler. However, there are other signs also on ultrasound, but the first thing you will do is the middle cerebral artery peak systolic velocity. Remember, agar kisi bhi, for a normal human being, if the blood is becoming anemic, it is becoming more and more thinner, the velocity will increase, isn't it? So remember, the MCA velocity will increase, and once it crosses more than 1.5 moms, okay, this is a standard number which has been taken. If it crosses this number, that is the time when intervention has to be done for the baby. But जब तक ये क्रॉस नहीं हो रहा, we will just keep on monitoring the baby with the help of middle cerebral artery, the velocity of the blood, also other signs of the fetal anemia, okay, like fetal hydrops, fetal swelling, fetal fluid collection in the pericardial cavity, in the peritoneal cavity, etc. So Rh negative mother, as I told you, we will see the titer. If it is negative, this means the mother के पास antibody नहीं है. That is a very good thing, because now we will immunize the patient. Okay, so you will give anti-D. Suppose now you know the titer. If it is less than critical titer, this is also good news. You just have to follow up with the titer. Okay, and whenever if the value remains below the titer, deliver the patient between 37 to 38 weeks. Now suppose as we see the value of the antibody is more than the critical titer, so in this we have to see how much hemolysis is happening to the baby. It was done in past with the help of amniocentesis, in which the bilirubin was also released into the amniotic fluid, and we will measure that bilirubin in the amniotic fluid. But it's an invasive procedure. We don't do it now. We now do MCA PSV. Okay, so the option will be estimate the MCA PSV. So suppose there is a similar question. Rh negative female, para 3 has antibody titer of 15 international units. Now at 28 weeks, ultrasound is revealing features of hydrops and polyhydropneus. Now what you will do? Abhi kya hua? The critical titer has crossed, but now the baby is already showing the signs of fetal anemia. Okay, till now in the previous question, fetal anemia was not there. How will you start measuring? With the help of MCA PSV and other these signs I told you. But now in this question, already the baby is having anemia. If the baby is already having anemia, simple answer is what? You will give the blood transfusion. Okay, so how do you do that? You will perform the intrauterine transfusion. But again, remember, this is the treatment. Okay, read the question properly. What is the next most appropriate management? Next step. What will be the next step? Okay, when the question is next step is not straight away intratransfusion. I will first estimate कि fetal hemoglobin कितना है. Fetal hemoglobin by cordocentesis. Cordocentesis means umbilical cord के umbilical vein में I will prick and I will take out the blood and I will estimate the hemoglobin of that baby. Okay. So first I will perform the cordocentesis to estimate the fetal hemoglobin. I will calculate how much blood has to be given to this baby. O negative blood has to be given to such babies, and it can be given with the help of intravenous transfusion or even intraperitoneal transfusion to the baby. Okay. So I hope all this session was useful to you. I know there are some questions remaining which I would like to continue in the next session. I would love your feedback, and any doubts you have, please share them on the message, and any other suggestions are most welcome. Thank you so much for this class. Thank you.